Breaking the wall of excess mortality after cancer. Andreina, Kero, Turku University Hospital, Finland.
Good morning. This is a great opportunity to speak about childhood cancer. 200,000 children are diagnosed with cancer below the age of 15 years worldwide every year. What is their prognosis? It actually has improved, and rates are actually exceeding 90% for certain standard risk cancers. In average, 1 out of 8 children won't survive from cancer. But this is overshadowed because 2 out of 3 of those survivors will suffer from long-term health complications. And cancer is the most feared health complication, but cardiovascular complications are the dominant non-cancer-related complications. In Finland, we looked at the myocardial infarction, heart infarct, after childhood cancer. And as you can see, even 30 years from cancer diagnosis, there is an increased risk compared to the baseline risk in the standard population. What are the risk factors? Drug exposures, specifically anthracyclines, have been associated with cardiovascular complications, but they cannot be omitted because they are a center part of chemotherapy. Chest radiation, and genetics. So these childhood cancer survivors are at 4-fold risk to die from cardiovascular diseases after surviving cancer. So we want to break this wall. We want to look at the pharmacogenetics of anthracycline metabolizing genes, look at the saliva samples, blood samples from childhood cancer patients with similar diagnosis, having received similar therapies, similar age ranges, and then identify those in red with the cardiovascular complications and those without, and then look GWAS, SNPs, genetic studies, and look at the anthracycline metabolizing gene variations that are associated with those cardiovascular risks. So we wanted to actually promote the therapy, improve it, that we spare those childhood cancer survivors from those potentially deadly cardiovascular complications. So the vision is, at the cancer diagnosis with childhood cancer, we look at the recommended cancer therapy, maximally targeting the cancer, looking also at the cardiovascular risk profile and our new information of the anthracycline-associated gene polymorphisms, these genetic variations associated with those risks. When we can look at, identify them, we can also screen for them, and then actually look at the maximal dose we can give to target the cancer, but also to reduce the risk of cardiovascular complications at the same time. There is a vision that no child should die from childhood cancer. My vision is that they should not die from childhood cancer, but after cancer survival, they should not die from cardiovascular complications.